Hello, my name is Stefan Zimmerman. I'm an assistant professor here at Johns Hopkins University in the Department of Radiology. And today we're going to talk about cardiac CT and review normal anatomy and variants. So first, an outline. This is what we're going to review today. First, we'll go over the coronary arteries and discuss the major epicardial vessels and their branches. Talk a little bit about dominance, vascular territories, and then review anomalous coronary arteries. And in the second part of the lecture, we're going to talk about the cardiac chambers themselves and review some of the features of the ventricles, the atria, and the pericardium. So first, the epicardial coronary arteries. This is a sort of a comprehensive list of all the epicardial coronary arteries that we concern ourselves with in cardiac CT and cardiac catheterization. We're going to review each one individually and talk about their anatomy, their branches, and what vascular territory they supply. So the epicardial coronary arteries, this is a volume rendered image showing the heart from an anterior projection. And when we take a look at the heart, we're tilted a little bit cranially here. You see the major epicardial coronary branches on the surface of the heart. The first one here labeled on the top is the left main, so this is arising from the left side of the ascending aorta. And it branches into an LAD branch, which we see, and that comes towards us in the groove between the right ventricle and the left ventricle. And then the RCA we're going to see on the right side here, and that one comes off to the right and goes in this groove between what is the right atrium here and the right ventricle here. So let's talk about them in a little more detail. Actually, I'm sorry, first we're going to show the origins in a different view. This is a short axis view looking down on the aortic valve region. This is just actually above the aortic valve, parallel to the valve. And what we're looking at here is the coronary sinuses, and these are the origins of the coronary arteries. So the right coronary artery originates more anteriorly from the right coronary sinus and heads over to that AV groove that we saw before. The left main coronary artery arises posteriorly, somewhere in the kind of the 3 o'clock to 6 o'clock position, and branches off into the LAD and the circumflex coronary artery. The names of the coronary cusps are named for the actual coronary vessels that arise from them. So this is the right coronary cusp and the left coronary cusp, and this last one is called the non-coronary cusp, and that one you can always recognize because it points to the interatrial septum posteriorly. So let's first talk a little bit about the right coronary artery. The right coronary artery arises from the right coronary sinus, as we discussed. It runs in the right atrioventricular groove and heads towards the inferior interventricular septum. It supplies, generally in most people, supplies blood to the sinoatrial node. This is the pacemaker of the heart, and also supplies blood to the right atrium and the right ventricle. Its branches, usually the first branch in the majority of patients is the conus branch, a small branch supplying the conus part of the heart, which is also known as the right ventricular outflow tract. This branch heads anteriorly and supplies that tissue in the heart. Then there's the sinoatrial nodal artery. Then you have atrial branches and RV branches, which can be variable in size, and oftentimes we don't really see them on cardiac CT because they're so small. Usually we'll see at least one large branch, and the first largest of these is called the acute marginal branch. Typically this is going to originate somewhere around the margin of the heart, which is where the more vertically oriented portion of the right ventricle meets the more horizontally oriented portion of the right ventricular wall. That's the acute marginal branch. And then the last branch in the majority of patients is the posterior descending coronary artery, or the PDA. This is the vessel that goes along the inferior wall of the heart and supplies blood to the right ventricle as well as the inferior aspect of the septum. So the most important branch really off of the right coronary artery. So here's an example of coronary artery anatomy. On the right side of the image, we have, or the right side of the slide, I should say, we have an axial image. So this is how we're typically going to see the RCA arising here anteriorly. Again, right around the 12 o'clock position. Usually it's somewhere between 9 and 12 o'clock, and heading off towards the right AV groove. If we do a short axis reconstruction, which is my preferred way to really look at the right coronary artery, some people call it a C view as well. Basically what we're doing is we're parallel to the mitral and tricuspid valves, and we're looking back at the right coronary artery in its entirety from the proximal, mid to distal portions. Really shows the anatomy nicely here. So this is a nice view of the right coronary artery as it wraps around the AV groove. And the nomenclature of the right coronary artery is here. And basically, we have 3 portions, kind of analogous a little bit to the duodenum, which has 4 portions, but similar concept where you have a proximal kind of horizontal portion, a middle, more vertical portion, and then a distal, more horizontal portion. And so there's no vessel that defines the interface between the proximal and the middle portions. It's more an eyeballing thing where you basically just see where is that transition from the more horizontal to the middle vertical portion. The acute marginal branch is going to come off usually around this area. That's the acute angle of the heart where the vertical portion meets the inferior horizontal portion. Here's some examples of disease in the right coronary artery. This is a patient on the left side of the screen which has actually a long area of stenosis in the right coronary artery from here to here, and you don't actually see very good filling with contrast. So this is likely a long occlusion of the right coronary artery. We see that on occasion. There's also some calcification proximally and distally. This is a different patient on the right side of the image who has a very ectatic and dilated right coronary artery with lots and lots of calcification and even an aneurysm here, right at the junction of the proximal and the middle portions of the RCA. You can see this aneurysm is filled with either thrombus or plaque, and this is a heavily diseased RCA. You can see you're just getting a glimpse of the left main and the circumflex here, which are also heavily diseased. Just one more example, or a couple more examples. This is another ectatic, dilated right coronary artery with some mild disease, maybe some more moderate disease proximally. And then this is a curved planar image, which we'll talk about in a little bit. This is a way that we can lay out the vessels and get a good visualization of the vessel from proximal to distal all in one image. And you can see there's some mild non-calcified plaque here and here in this patient, but nothing that really causes any significant luminal narrowing. All right, so let's review a little bit the branches off the right coronary artery. So this is a volume rendered view, kind of an anterior projection showing the acute marginal branch coming off. And again, variable from person to person, but usually somewhere in the middle to distal portion of the right coronary artery or right at their junction is where it arises. This vessel, to be honest, when we're reading cardiac CT, we don't pay it too much attention. Generally, it is not a vessel that gets intervened upon, meaning that they would not, if they saw plaque there on cath, they generally do not fix it. They don't put a stent in. They don't bypass that vessel. So it's not typically something we care too much about on cardiac CT. What are the other branches? So the most important branch is the PDA. That's the one that supplies the inferior aspect of the septum and the inferior aspect of the heart. If the LAD is small, the PDA can even wrap around the apex of the heart and supply the inferior third of the septum and the apex of the heart, which makes it even more important in those patients. There are also usually some extra branches to the inferior wall of the left ventricle called the posterior left ventricular branches or posterolateral branches. PLB is one abbreviation you may see, and these supply the inferior wall of the left ventricle as well. So what are some coronary artery variants? For the RCA, I discussed a little bit the conus branch, and this is a tiny branch you see there on the left-sided image, and more anteriorly on the right-sided image. The conus branch is this small branch that goes and supplies the area of the RVOT, which you can see nicely here on the right-sided image. The conus branch is, again, not an important branch. It's more just a landmark. Turns out that in some patients, the conus branch can actually arise directly from the right cusp in 30 to 35% of patients. The only reason that's important is just don't get faked out at, think it's something else, something more important, some sort of important anomaly. It's just a normal variant. And this is the SA nodal branch, which we talked about, a little branch that heads posteriorly to supply the SA node, which actually lives along the back wall of the right atrium right here. So most of the time, 60% of people comes from the RCA, but in 40% actually can come from the circumflex. I'll show some examples of that later. So what does the PDA look like? What do the posterolateral branches look like? Here's a nice image, basically we're an inferior aspect of the heart on an axial MIP here, and we see a nice example of the PDA branch, which is going down the septum here, or riding along the septum, I should say, and supplying the septum with blood. And then here's a posterolateral branch, which basically it's a continuation of the PDA, a continuation of the RCA after the PDA comes off, and then curves around to supply the inferior wall of the left ventricle. So both these vessels are important and could be potential targets for bypass and or stenting if there's significant disease in these vessels. This is a good time to talk a little bit about coronary artery dominance. So the majority of patients not just patients, but the majority of people have right dominant coronary system, which you see all the way on the left. That's 80% of people, and in that case, the PDA and the posterolateral branches arise from the right coronary artery. In the middle, you have about 10% of patients have a left dominant system, and in that case, all those branches come off of the circumflex. And then you can get into a situation where you have a codominant system. In those patients, you have PDA coming off of the RCA, and the posterolateral branches actually arise from the circumflex. So you have both the right and the left contributing to these branches, and that's the codominant system, making up another 10%. Okay, so that really sums up the RCA. Now let's talk a little bit about the left main coronary artery. So the left main coronary artery arises from the left sinus, as we already showed. In some patients, actually, it can be absent. Less than 1% of patients, and you'll have separate origins of the LAD and circumflex from the left sinus. But in the majority of patients, 99% of people, it's present. It can be quite variable in length, sometimes very, very short, or sometimes quite long, and that's all within the range of normal. It gives rise to the LAD and circumflex, and in about 15% of patients, it also gives rise to the ramus branch at a trifurcation. So we'll show some examples of that. Here's the volume rendered view on the left side. This is a nice volume rendered image showing the left main coming out at us and immediately branching. This is a short left main, immediately branching into an LAD and a circumflex coronary arteries. And then you see some more distally, you see some LAD branches, which we'll talk about later. Those are called the diagonal branches. On the right side of the image, we see another example of a left main. This is a longer left main. So we talked that they can be quite variable in length. So this is a short one. This is a long one. Totally normal, just another example of kind of the normal variation in coronary anatomy. Here's a third example. This is a left main with a trifurcation. So in this case, the patient has, again, a short left main, and then it trifurcates into 3 vessels. This one heading towards the chest wall is the LAD, and then this is the circumflex heading towards the AV groove. And then the one in between is going to be the ramus branch, and you can see these vessels are heavily diseased with lots and lots of calcium. So what about the LAD, or the left anterior descending coronary artery? This is the most important coronary artery, really, in the at least that we worry about generally in the heart. Typically, a lot of the major disease happens here, and this is often the culprit, and people have heart attacks. So it arises from the left main, as we saw. It courses inferiorly in the anterior interventricular groove between the right and left ventricles. It gives rise to diagonal branches, and these are numbered 1 through however many you have. So generally on cardiac CT, we're reading them, we number the diagonal branches, which are large enough for us to evaluate. Usually those are more than 1.5 millimeters or so. The number and size of the diagonal branches is quite variable, and so in some patients you might see several large diagonal branches. In other patients you may see virtually no diagonal branches at all. That's all okay. That's just, again, the normal variation in coronary anatomy. These branches supply the anterior wall of the left ventricle. The LAD also gives rise to septal perforators. These dive downward into the septum and supply the anterior 2/3 of the interventricular septum. Generally, we don't find coronary artery disease in these septal perforators, and they're not something we pay a lot of attention to. They're also pretty hard to see because they're very small. So these usually aren't a focus when we're doing our cardiac CT examinations. The LAD itself may actually wrap around the apex and supply the apical inferior wall or the septum in some patients. This is a good time to talk about coronary artery territories. So generally, for the majority of patients, the different coronary arteries supply different territories of the left ventricle. So they're responsible for different walls, providing the blood flow to different walls of the ventricle. So you can see that part of the reason the LAD is considered such an important vessel is it supplies almost half of the myocardial tissue here. The anterior wall and the septum are really the LAD's responsibility, with the very, very inferior aspect of the septum and the inferior wall supplied by the RCA and those posterolateral branches. And then the circumflex usually supplies the lateral wall, and we'll show some examples of that later. Incidentally, this patient had an LAD stenosis. That's why you see that the enhancement of the LAD here is relatively low compared to the enhancement of the myocardium inferiorly supplied by the RCA. So there's relative ischemia here in this patient who was actually having acute symptoms. Just another example of the LAD here. Nice volume rendered image on the left showing you the LAD here and multiple diagonal branches here. So one big one there, another one that splits into two other branches here. So this is these volume rendered images can give you a nice overview of the cardiac anatomy, and certainly good for showing to referring clinicians to give them a sense of what the coronaries look like. This is a MIP image of not the same patient, but kind of a similar image. This person has a ramus branch you can see here, and then also some diagonal branches, D1 and D2. Again, these diagonal branches can be quite variable in number. The diagonals usually come off and head towards the lateral wall of the LV, whereas the septal branches go the opposite direction. They come off and head towards the right side and down. These little branches you see here, and again, we don't really worry about those too much. Here's just an example of an LAD in a patient. This patient has some stenosis denoted by the arrow here. This is soft plaque. The patient was symptomatic, having accelerating angina symptoms. And this patient ended up going to coronary catheterization and getting this fixed. Just a nice image, though, showing you on the MPR and the curved planar views the course of the LAD in this groove between the right and the left ventricles, and how it kind of wraps over the anterior wall and toward the apex of the heart, and this patient has this nice stenosis here. Okay, this is a lateral or sort of a sagittal view of the LAD in the MIP format, and it's nicely labeled here and actually shows you some of these septal perforator branches. They head inferiorly, dive down into the septum and supply the myocardium of the septum itself. So we've got 1, 2, and 3 here. Again, generally these are not important. We don't tend to describe them at all in our cardiac CT reports because you usually just do not have any cardiac disease in these branches. The other thing we see here on this image is myocardial bridging. These two arrows here are pointing out an area of the LAD where it's actually surrounded by myocardium. So the myocardium is actually wrapping around the LAD in its mid portion here. So this is myocardial bridging. So the coronary artery actually is traveling, instead of on the epicardium surrounded by fat, it now dives into the myocardium here and is surrounded by muscle. And then later on it pokes back out again, back into the epicardium surrounded by fat again. So you can recognize this by the change from epicardial tissue to fat, epicardial fat to muscle surrounding the coronary. What is the significance? Really no significance at all. In the vast majority of people, we see these incidentally, and they're really not of any importance. Some studies have looked at the presence of myocardial bridging in outcomes, and generally they're not associated with any worsened outcomes in patients. There are some studies that have used nuclear perfusion methods to look at the presence or absence of ischemia in association with myocardial bridging, and some reports have shown that you can have some ischemia and anginal symptoms in severe cases of bridging. So usually our kind of rule of thumb is if we see a very deep bridge or a long bridge and the patient has no other explanation for their symptoms, that might be worthwhile getting a stress test in that patient if there's continued concern for possible anginal symptoms. So we talked a little bit before about the nomenclature for the RCA. Now let's review LAD nomenclature. And this is, I'm referring to the nomenclature set forth by the Society of Cardiovascular CT. There's also a naming system which has been put forth by American Heart, which is just a little bit different, has a couple more segments. I tend to use the SECT because it's just a little simpler and a little easier to remember, but either one is really fine. In this nomenclature, the proximal, mid, and distal portions of the LAD are defined by the LAD branches. So for instance, the proximal LAD is the portion of the LAD from the end of the left main to the first large septal or first diagonal branch, whichever is most proximal. So it ends up that a lot of times you actually have patients with a very, very short proximal LAD because that first diagonal branch or first septal perforator may come off pretty early in some patients. The mid-LAD, though, is not defined by any branch distally, but rather it's the end of the proximal LAD to half the distance to the apex. So that's a little easier. So sometimes you end up with a very small proximal and a fairly large mid LAD segments, and then the distal LAD is halfway to the apex all the way to the end of the LAD, so that's easy to remember. Okay, so that wraps up the LAD. Let's talk a little bit about the other major coronary artery, and that's the circumflex. So the circumflex also arises from the left main. It courses inferiorly in the left AV groove, so it's basically kind of the partner to the RCA on the opposite side of the heart. It gives rise to obtuse marginal branches, so the RCA acute marginal branches, the circumflex obtuse marginal branches, and these are numbered, again, OM1 through however many you have, so usually you have at least a couple decent-sized obtuse marginal branches. Again, they're highly variable in size and number, and particularly in the setting of a ramus branch, they may be either quite small or even absent from view, at least on cardiac CT. They may be too small to see. These branches generally supply the lateral wall of the left ventricle. Like we talked about in a minority of patients, you may see that the SA nodal artery arises from the circumflex. And also in a small minority of patients, you may see a left dominant system where the PDA arises from the circumflex coronary artery. So what does it look like? Here's an example. So on an axial image, usually you see the circumflex as a tiny dot in the AV groove here. And then if you do some manipulation and you create a MIP, you can actually lay out the vessel nicely. And you can see here, this is left main branching into an LAD branch here and a circumflex branch here. And it's coursing along. This is the left atrium, left ventricle. So it's going right in that groove between the left atrium and the left ventricle. The C view that we use for the RCA, which I touched on before, actually is also a pretty good view most of the time for looking at the circumflex coronary artery. A lot of times it travels at slightly a different angle compared to the RCA, so it may require a little bit of adjustment to get that circumflex vessel laid out on the C view, but a lot of times this view is a really nice way to lay the circumflex coronary artery out and get a good assessment of the vessel from the proximal portion to the distal. What about the nomenclature? So the circumflex and the SCCT nomenclature, actually it's pretty simple. You have a proximal and a mid/distal, so they just lump the mid and distal together. And the proximal is defined by the origin of the circumflex to the first obtuse marginal, and then the mid/distal segment is all the rest of the circumflex. So here's an example of a case that we had several years back. This is a patient actually who had used crack cocaine before showing up to the emergency department with chest pain. And so this, on the right side, where the arrow is pointing to, this very, very small, thready circumflex coronary artery where it gets really, really narrow and then disappears for a segment here in the proximal segment and then comes back again. And here's kind of an oblique axial view, which shows the same thing, very thready little circumflex, disappears and comes back. So this was an example of vasospasm. Actually on our perfusion images, this was first pass perfusion. We were able to window, and you can actually see that there is hypoperfusion or reduced perfusion of the lateral wall supplied by the circumflex. So this is a really nice demonstration of the vascular territory that's supplied by the circumflex coronary artery. So this patient was symptomatic. They treated him with calcium channel blockers, and it actually got better, and they sent him home. Okay, so back to our outline. So we talked about the major epicardial coronaries, the dominants, and the vascular territories. So next we're going to move on to some variants, talk about anomalous coronary arteries. So just as kind of an overview, coronary arteries are quite rare. So this is an old study, but some of the biggest and sort of the best data we have available, at least, kind of the standard now for what we use to talk about prevalence of coronary artery anomalies. This study was done back in 1950, a catheter angio study, and they saw that roughly most coronary arteries have a prevalence of roughly somewhere a little bit less than 1% in the population. So for instance, if you look, aberrant left main coronary artery, about 0.7%, circumflex, 0.7%, and so on and so forth. So generally, what I just say is most of these coronary artery anomalies are pretty rare, and usually it's less than 1% of the population. So the most scary one, and the one that we're always worried about, is the anomalous left main origin, or the malignant course, and that's when the left coronary artery arises from the right sinus and passes in between the aorta here and the pulmonary artery here. And in this case, the left main can only be visualized as a tiny, tiny little thread between these two vessels. So it's being compressed in this space between the aorta and the pulmonary artery. So this is very dangerous and has a high risk of sudden cardiac death. And so, for instance, in this patient, this image, the patient actually came after having collapsed on a treadmill while exercising and had to be resuscitated. So certainly a very risky lesion. That's why it's called a malignant course. It turns out, interestingly, that a lot of times this is associated with an intramural course. So if you look at this pathology image, you actually see that the vessel actually travels within the wall of the aorta here. So in this space between the aorta and the pulmonary artery, oftentimes you'll see the vessel traveling in the wall of the aorta and then distally popping out. Here's another example. This is the origin traveling within the wall. It gets a little compressed here, so you can't see the origin, can't see the vessel anymore, but then distally it pops out here on the other side. So this intramural course actually is interesting because it's actually important to know for the surgeons. It helps with their planning. They can do what's called an unroofing procedure, where they actually cut away this excess tissue here and create a new ostium, which is not being compressed down distally, where the vessel is actually popping out and heading towards the anterior interventricular groove. So the presence of an intramural course is important. So how do you know if there's an intramural course? Well, it's not, at least the current literature is still a little bit sparse on the topic, but at least most experts would agree that the intramural course is suggested by this appearance here on a sagittal view, and that is this slit-like narrowing, which is sort of the term used in the literature, where the left main coronary artery is much, much taller than it is wide. Usually, at least that's most people seem to think that is associated with a intramural course. And so if you see that usually means that's the portion of the coronary artery that is within the wall of the aorta. And so that would facilitate this unroofing procedure. What are some other anomalies of the left coronary origin? So that was the malignant course. Actually, just an aside, so one can have a malignant course without an intramural course. So if you see that the vessel is passing between the aorta and the pulmonary artery but doesn't have this slit-like appearance, you do encounter that sometimes. That's still a malignant course, meaning it's still risky, still has the same risk or a similar risk of sudden death, but it does not necessarily have an intramural course, and that may actually affect surgical planning, because that basically makes it so that unroofing procedure is no longer an option. Okay, so back to other types of coronary artery anomalies. So the left coronary artery can have other anomalous origins. On the left side of the slide, you can see an example of the left coronary artery arising from the right and passing posterior to the aorta. This is called a retroaortic course. It may come off the right coronary artery, or it may come off the right coronary sinus by itself. Either one. The important thing here is that it's benign. You can see it wrapping around the aorta here posteriorly, so there's no compression in this situation. This is a benign anomaly. You do not need to worry about it. The other benign anomaly of the left coronary you may see is that it can arise from the right side, either from the cusp or from the RCA itself, and then pass anteriorly in front of the pulmonary artery here, which you can see on this example and in this figure. And if that happens, that's also a benign variant. So again, there's no compression in this situation. Patients do fine. This is a volume rendered image showing it passing anterior to the right ventricular outflow tract. So that's okay. What about anomalies of the RCA? So you can get similar malignant course of the RCA like you do on the left side. This is an example, a patient who has the right coronary artery originating from the left side and passing here between the aorta and the pulmonary artery. So again, this is considered a malignant course and considered risky. However, as an aside, generally the right coronary artery management is not quite as definitive as the left. For instance, if you see a malignant course of the left coronary artery, that's pretty much always going to be fixed. Right coronary artery, it's a little bit less certain. particularly if incidentally discovered. A lot of times these patients will be left alone. The risk associated with this is not as well defined. Certainly there are case reports of people having sudden death because of these right coronary anomalies, but it's a little bit uncertain what to do in somebody who is asymptomatic. And as a prophylactic, whether a prophylactic repair is necessary. This is actually a nice example of an anomalous right coronary and an example of somebody who does not have an intramural course that we can see, at least, where you don't see that narrowing or acute angulation. On the sagittal view, there is no slit-like appearance. The vessel maintains a normal caliber here, so this patient does not have an intramural course, so therefore they would likely not be a candidate for the unroofing procedure, that may affect surgical management down the road. Another note about RCA anomalies, you can also have, transitioning over to circumflex anomalies. On the bottom right, we see an image of a anomalous circumflex. So you may just get the circumflex arising in isolation from the RCA or the right cusp and having a retroaortic course. Again, this is benign. On the left side, you see a high origin of the right coronary artery, which we sometimes see, and that high origin passes between the aorta and the pulmonary artery. So it's, again, an interarterial course, but the management is still a little bit uncertain, and certainly depends a lot upon sort of local practice patterns. What about other anomalies? Are there any other anomalies we encounter? Yes. This is a very rare disease, Al kappa and or R kappa. These are two diseases in which the origin of the coronary artery is abnormal. The Al kappa stands for anomalous origin of the left coronary artery from the pulmonary artery. And in these cases, what you have is that the left coronary artery arises from the pulmonary artery, which is demonstrated here. And what happens is, because the pulmonary artery is low pressure and the coronary artery is systemic or high pressure, the blood actually flows retrograde through the coronary artery into the pulmonary artery, and this acts as a kind of a sump, and it pulls blood flow out of the coronaries. It creates ischemia in the left ventricle because of that, and also leads to high output of blood via the normal right coronary artery, and you get these really, really dilated and tortuous coronary arteries, which is really classic for this disease. You can have the right coronary artery also originating from the pulmonary artery. That's called R kappa, a little more rare than Al kappa, but in both cases you're going to see these really, really dilated coronary arteries and the anomalous origin directly from the pulmonary artery. Other things you can see coronary fistulae. So coronary fistulae basically are, unlike R kappa and Al kappa, where we have an anomalous origin, in this case we're talking about an anomalous termination of the coronary artery. So a lot of times you may have a little branch off of a diagonal, such as in this case, a little branch that goes and terminates into the pulmonary artery. You can see that. You can see branches terminating into the SVC, right atrium, left atrium. If they terminate in a chamber, they actually have a different name. They're called coronary cameral fistulas. So any coronary to ventricle fistula is called a coronary cameral fistula. Coronary to pulmonary artery, like I said, you can see sometimes coronary to coronary sinus is a common one that you may see. And oftentimes they have a variable appearance. Sometimes you'll see a little dilated branch and maybe an aneurysm. Other times you might see that the coronary itself, which is involved in the fistula, is dilated, and so it does have a variable appearance. Here's an example of a patient. This is a baby who had pulmonary atresia with intact ventricular septum, and it turns out that particular disease has a relatively high association with coronary cameral fistulas. So you can see this is the distal LAD actually attaching to the apex of the right ventricle, the flowing into the RV cavity, and here's actually a more proximal aspect of the LAD also communicating with the right ventricular cavity. So that's a coronary cameral fistula. Okay, so what are the take-home points for the coronary artery anatomy? First, it's important to know the typical appearance and nomenclature of the coronaries. Just to remind you, branch coronary arteries are highly variable in appearance. Anomalies are rare but can be life-threatening, so always be on the lookout. And if you see really big coronary arteries diffusely dilated, think about the Al kappa, R kappa, or maybe coronary artery fistulas. So part 2, we're going to talk about the cardiac chambers. In this case, we're going to review ventricles, atria, and pericardium. So let's talk a little bit about the features of the right ventricle and the left ventricle. So the right ventricle is interesting. It has some similarities and differences from the left ventricle. So the key features we look for, coarse apical trabeculations, a septal leaflet of the tricuspid valve that connects the interventricular septum, moderator band, and a muscular infundibulum that separates the tricuspid and pulmonic valves. And I'll talk about all those in a second here. The left ventricle features, usually it's a little different. We have these very fine apical trabeculations, unlike the thickened and coarse trabeculations on the right side. We have anterolateral and posteromedial papillary muscles. We don't have any muscles attaching to the septum. And unlike the right side, we have continuity between the mitral and aortic valves, whereas on the right side, you have separation of the tricuspid and pulmonic valves. So here's some examples of RV features. These are these coarse apical trabeculations we discussed. So lots and lots of trabeculations in the RV. The moderator band is this band of tissue which obliquely courses from the septum out to the apex of the right ventricle. That's really characteristic of the RV. Whereas in the LV, we often have really either very small or almost absent apical trabeculations, and the morphology is dominated by these two large papillary muscles, which we see very well on short axis view. There's the anterolateral and posteromedial papillary muscle. We see them also on axial views. Notice there's nothing here of any significance attaching to the septum. That's another distinguishing feature. Oftentimes, or typically in the RV, you have trabeculations attaching to the septum, not so much in the LV. Here's another example showing you these fine apical trabeculations. LV also has a mitral valve with 2 leaflets, an anterior leaflet and a posterior leaflet, whereas the right ventricle has a tricuspid valve with 3 leaflets. So LV, oftentimes we can see very well on cardiac CT the mitral valve leaflets, where it's a little bit harder to see the tricuspid leaflets on standard cardiac CTs unless we are specifically looking at the right side. Okay, what about the atria? So what do the atria look like? So this is a nice series of images going from top to bottom through the left atrium. This is the left atrial appendage, left superior and right superior pulmonary veins. They drain into the left atrium. As we go more inferiorly, you start to see the left atrial appendages going away, and we get right here where we get this little piece of tissue which is separating the left pulmonary vein, left superior pulmonary vein from the left atrial appendage. This actually has a special name. It's called the ligament of Marshall, or the Q-tip. The reason it's called the Q-tip is because sometimes the end of it can have a bulbous or enlarged appearance that can look kind of like a Q-tip, maybe even infiltrated by fat in some patients, so just something to be aware of. As we course more inferiorly, you start to see more of the left atrial cavity itself. This is the right inferior pulmonary vein and the mitral valve now. This is a little flap of tissue that you may occasionally see, which is a remnant of the fossa-valgus, or the, I'm sorry, not the fossa-valgus, but rather a remnant of the flap valve that lived there when patients have in fetal life a patent foramen ovale. This is a little bit of a remnant of that still hangs around sometimes in people. And so you may see a little bit of tissue here. That's fine. That's all within the range of normal. And this is the mitral valve orifice where the left atrium empties its blood to the LV. Here's just another example of this concept of the remnant tissue from fetal life. So again, in fetal life, you have the atrial septum, which is composed of 2 components, the septum primum and secundum. And in fetal life, there's basically a space between those two, a valve that exists, and the blood can flow between the two to allow the blood to cross over from the right side to the left side in fetal life. But in adult life, that valve closes up. And in some patients, you may have incomplete fusion of this primum and secundum, which you see here, and a little bit of extra tissue here, which hasn't completely fused. And that's normal. That's okay. It's not really a problem. It creates a pouch, so some people call it a septal pouch. Here's an example, a gross example of what it looks like. If this bottom half going to the right side is open, then you may actually get blood flow across it, and in that case you have what's called a patent foramen ovale, so you have this intermittent flow across the interatrial septum. And this has been associated with higher risk of cryptogenic stroke, but the management of these patients is still a little bit unclear. This ligament of Marshall, we mentioned it does have one association with pathology, and that is if somebody has this entity called Triatriatum, usually that is originating from the ligament of Marshall. So in this case, this is an example of a person with partial Triatriatum, and that means that you have this membrane basically in the middle of the left atrium separating the more anterior mitral valve portion from the more posterior pulmonary vein portion. And that membrane usually arises from the ligament of Marshall area and heads over to the fossa ovalis. So that's kind of the only real example of pathology, at least imaging-wise, that we see associated with this ligament of Marshall. So just some notes about pulmonary veins. So sometimes we're asked to do cardiac CT to help with planning of catheter ablation of atrial fibrillation. And in those cases, they're often using our CT data to map the pulmonary veins. So for them, actually, anatomic variants of the pulmonary veins become very important and help kind of determine where they're going to do their catheter ablations. And so if you see pulmonary vein variants, it's important to mention, particularly if you're doing a study for ablation mapping. Oftentimes what we see is that on the right side, you may have, lost my mouse here, let's see. On the right side, you may have extra pulmonary veins. Oftentimes, you may have a right middle branch that's separate on the right side, whereas on the left side, you may more commonly see a common ostium, where the left superior and left inferior pulmonary veins come together as one. And then rarely you may see these pulmonary veins which are kind of extra and just sort of stick in wherever they feel like, sometimes into the roof of the left atrium, sometimes the posterior wall, and those certainly are important to mention as well. Okay, now switching gears over to the right atrium. What does the right atrium look like? The right atrium basically starts right where the SVC here joins the right atrium. So this is the SVC. Anterior to the SVC, you're going to see this right atrial appendage, which has this broad base and really lies on top of the ascending aorta. As we go inferiorly, you'll start to see this ridge. So the continuation of the SVC and that interface between the right atrial wall and the SVC continues inferiorly as this ridge between this smooth portion of the right atrium and the trabeculated portion of the right atrium. And that ridge is the Crista terminalis, and that's actually where the sinoatrial node lives. So the SA nodal artery, if you see it, you'll see it going to this area. And that's an important structure in that sometimes it can be mistaken for disease or for a mass, so it's just important to know that there is some variability in the appearance of the Crista terminalis. It can be quite large in some patients, and that's okay. Usually, oftentimes, actually, you'll see fat within it. As we travel more inferiorly, you'll see the right atrium here, and you see the tricuspid valve, so all the right atrial blood is going to dump into the right ventricle via the tricuspid valve. And then more inferiorly, you see the interface of the right atrium with the inferior vena cava, and you often get a little bit of tissue there called the eustachian ridge. And that's a little bit sort of like a valve flap that sometimes can sit on top of the SVC-RA junction, and it's not really important, just important to recognize that it exists. Here's a right atrial, sort of a cartoon showing the right atrial anatomy. If you were able to fillet open the heart, this is that smooth portion that we talked about, so more posteriorly directed, where the SVC and the IVC join the right atrium. And here's that more trabeculated lateral wall. And this is that ridge separating the two called the Crista terminalis, which courses inferior to superior in a vertical fashion. And then more anteriorly, you're going to see the tricuspid valve here. There's other structures here. There's a coronary sinuses draining in here, and then you have a little bit of a ridge here. That's our eustachian valve, or eustachian ridge, it's called, right there, separating the two. So here's an example of the Crista terminalis in several different patients, just showing some variability. This patient's kind of more triangular shaped, a little more bulbous here in this patient, more kind of flat and lumpy in this guy, and kind of a little more laterally displaced in this patient. So bottom line, there's a lot of variability in the Crista terminalis. It courses superior to inferior in a vertical direction, so that's how you can recognize it, and oftentimes it has some fat in it. The eustachian ridge / valve also has variations, and so this is actually pulled from the literature. A nice a study which showed different appearances of the ridge. Sometimes it's totally absent, sometimes it's little, sometimes it's very long, sometimes it gets infiltrated by fat and can be quite big. So again, that's all normal variations, but just important to recognize that this is not a pathologic issue here. And then the last thing I want to touch on about cardiac anatomy, this is something we see quite often. It's called lipomatous hypertrophy of the interatrial septum. So it's not unusual to see a lot of fat infiltration around the atria, and particularly in the atrial septum here. Oftentimes it's more prominent posteriorly than anteriorly. Usually you'll get sparing of the fossa ovalis, which is this little dot here. So you get a lump of fat here, sparing in the middle, and then a lump of fat here more anteriorly. That's called the dumbbell appearance sometimes in the literature. Bottom line, this is a benign finding. It's nothing to be worried about. Occasionally, rarely, you may see a patient have obstructive symptoms because of the fat obstructing flow from the SVC to the RA, but that's pretty unusual. Generally, they can be quite large and really cause no symptoms whatsoever. Okay, so that sums up our review of the coronary and the chamber anatomy. It's just some take-home points. Know the characteristic features of the left and the right ventricles, and this becomes important if you do any congenital heart disease. It's important to know the different features and distinguish the right and left ventricles in patients who, there may be some abnormal relationships there between the right and the left side. Atrial anatomy is important to recognize and also report anomalies in patients who are being evaluated for electrophysiological studies. And then it's also helpful to understand the range of anatomic variation for normal structures that can be mistaken for masses. And that's it. I thank you for your attention.